any other company. So my name is Dr. Munjal. I'm a hardcore hemato-oncologist and bone marrow transplant fellow and practicing for last 20 years. Work in several countries, including Australia, Oman, UAE, India, Kenya, and other parts. And I'm life member of American Society of Clinical Oncology, US. So we have a regular updates and meeting in Chicago every year in June. So I'm like a quite more interested in academics. So I'm regularly visiting, trying to update myself. So that would be definitely benefited to you. I treated more than 100,000. This is old number, honestly speaking, and experience is 20 plus years and deliver thousands of lectures globally in various platforms, especially on hemato-oncology, and did thousands of bone marrow biopsy. Lots of videos are available how to do the bone marrow biopsies, interpretation, and stepwise approach. So this is Dr. Arti, Dr. Madi, Dr. Ankit, Dr. Shikha, all brilliant speaker in gynecpedia and internal medicine. Right. Here is our team. These all members. Right, Dr. Mariam, Sonal, and Pallavi. I cannot forget Pallavi. Definitely, she is like most of the time coordinating with you. So her picture will be updated soon. This is our latest copy of book. Those who are interested in book copies, right, they can ask for it. Several discounted package, and last but not the least, we recently come up with the dental course. We will going to launch soon by month end or next month first week. That is our deadline. So we have a excellent uh, this dentist from UAE, right? She is practicing in UAE, so she joined already and she designed the whole course. So we're going to launch soon. So those your near and dear and colleagues interested in dental course, like the way we are doing it for physician, general physician, family physicians, and all. And last but not the least, I strongly recommend each and everybody secret of success, right, is to see the at least one video per day. Medical MCQ for all is our website. I mean, sorry, YouTube channel. There are hundreds of videos uploaded on this channel, right? So you at least try to manage one video per day, one video per day. If you see it, you are solving close to 50 MCQ by my sense, right? So if you are seeing in month 30 videos means close to 1500 MCQ you can solve, right? So though there are 10 15 questions, but in one question I created 10 questions. So it's a very easy. If you are busy going driving on car or by bus or trams or travels, you can just open up and you can listen it, save your time, update your knowledge. And this is absolutely exam oriented questions only, right? And I'm not going in much detail of this, and we have almost I tried 56 MCQs, but today we'll discuss few of them. So let's start with the first questions without wasting the time. Rest of the things can be answered later. So 66 years old man comes to the physician for a 1 month history of fatigue. He has hypertension, hyperlipidemia. He has a transient ischemic attack 3 years ago. He drinks 3 beer per day, sometimes a couple more on social occasion. He currently takes aspirin, simvastatin, hydrochlorothiazide, metoprolol. His temperature is 37, pulse is 78, respiratory rate is 19, room air oxygen is 97. He is no apparently on distress. Physical examination show conjunctival pallor, multiple pinpoint red non-blanching spot on his extremities like limbs, upper lower, mainly lower limb. On abdominal examination, his spleen is enlarged. Laboratory study shows hemoglobin concentration of 8, leukocytes of 80,000, platelets are 34,000. Peripheral blood smear shows immature cells, large prominent nuclei, elongated needle-shaped cytoplasmic inclusion. Which of the following is most likely diagnosis? AML stands for acute myeloid leukemia. ALL stands for acute lymphoid leukemia. CML means chronic myeloid leukemia. CLL is chronic lymphoblastic leukemias. And last but not the least, MDS, that is myelodysplastic syndrome. And another thing is how you differentiate AML from ALL. That would be the next question. So think over it. Let's put your answer in the chat box. Give your own answer. Don't bias with someone else's answer, right? Because you need to post the answer in the exam. You can post your answer. We'll discuss everything in detail today. And make your mic mute if you are not answering. I'm muting all. Right. So I muted all. Right. If you want to discuss answer to speak, you can unmute your mic. You have facility down there in your chat box. Yes, I got only one answer out of 20 doctors already joined. So I need more 19 to answer verbally or post it in the chat box. Yes, Dr. Hazira, would you like to make any comment on this? Dr. Hazira, yes, you can unmute your mic and you can discuss. Yes, still there is only two answer, unfortunately. Right, so I wish you answer all. I mean, it's all high yield. It's all high yield. For you, just this lecture, you are sitting in the lecture 5 minutes ago. For this, I'm preparing whole week. Believe me. Yes, Nandini, your comment. Yes, yes, Nandini, you can unmute your mic.
So depending on the age, in the question, the age of the patient is 66 years.
Right. So, what is the diagnosis? First questions, basic questions. So, now let me ask you the couple of things if you don't mind. It's a learning platform, so obviously you learn a lot of things here for sure. So, here there are three things. This is a triad I give you every time. This is diagnosis, one arm is investigation, and another arm is treatment. So, now they are asking diagnosis. They ask you three things in exam. Either they ask you diagnosis, if they had given the diagnosis, they will or they may ask you investigation. If they have given diagnosis investigation, they may ask you the treatment as well. So first of all, tell me what is the diagnosis and what point favors for the diagnosis. Yes, Nandini. Yes, you can now start. Whatever is in your mind which favors the diagnosis, you can answer it, no problem. Yes, please. Is it very difficult questions you think? Anybody? Open for all. Anybody wants to comment?
So it's acute myeloid leukemia, sir.
Okay, so this is acute myeloid leukemia. Thank you, first of all, for participating and giving the answer. What point favors in these scenarios? Which favors this is acute myeloid leukemia, not acute lymphoid leukemia?
Yeah. So mainly age, acute lymphoid leukemia mostly occurs in children, and acute myeloid leukemia occurs in elderly people. And
Right. One is age,
differentiate
right?
between,
I'm
yes,
writing down
age.
here the criteria. So age, right? ALL usually seen more in pediatric age group. This is not a pediatric patient. This is 66 years. So this is one way by which you may think that this is AML. Okay, fine. What else? There are 10 points in this scenario which favors AML. I'll tell you one by one, all.
The organoids that needle-shaped cytoplasmic inclusions, it is pathognomic to AML.
Sorry, which cytoplasmic inclusion?
Needle-shaped
Needle-shaped
cytoplasmic
cytoplasmic inclusion. Is there any name of this needle-shaped
or
cytoplasmic inclusion?
organoids.
Excellent, brilliant. Air rods. This is OR rods, and OR rods is equal to AML. If you don't read anything, if somebody concentrate on this one line, needle-shaped inclusion. So this is a cell, this is nucleus, nucleolus, this is cytoplasm, and in the cytoplasm, there is a rod-like structure in the cytoplasm. We have MCQ on this, right? So this is called air rods, right? So it's needle-shaped cytoplasmic inclusion. It is OR rod, and OR rod is none other than AML, right? So if you see a OR rods anywhere in any scenarios, forget about scenario. If they are asking diagnosis and OR rod, AML. That's it. As simple as that. Fair enough. Next, how you differentiate AML from ALL? How you differentiate AML from ALL? Is there any head-to-head comparison that okay, this is AML, this is ALL? So anybody wants to give more clarity on this? So this is absolutely AML, this is not ALL. Any comment, anything? I would be glad and happy.
Presence of blast cells in AML.
Blast cell in AML. Okay, fine. So this is one of the things. So blast cell in AML. What else? Because there are blast cells can be seen in AML as well as in ALL. Blast is there in AML and ALL. You can see blast cell in ALL. It's a lymphoid blast. In myeloid, it is myeloid blast. So blast can be seen in both the things. So you cannot differentiate from the blast. I mean, number of the blast. Morphology of the blast you can differentiate, but you can say that blast cell is present in AML. Blast cell is not present in ALL. For your kind knowledge, it's present in both the blast, right? In acute leukemia, if it is blast cell is myeloblast, it is AML. Blast cell is lymphoblast, is ALL. So blast is present in both AML and ALL. Next, next comment. How you differentiate AML from ALL? One by age, right? We already understood, right? AML is usually seen in middle or elderly people, though it can happen. I have seen hundreds of patients so far, AML in pediatric age group, but more commonly in middle and old age patients, while ALL is in pediatric age group is more common. So this is one differentiating point by age. Second is OR rods. Somebody told OR rod. So OR rod is none other than AML. You cannot see OR rod in ALL. So second differentiating point. What else? What third? These are the two only points by which you differentiate. And let me tell you, those who have not clear idea, OR rod is not always present in 100% of AML, right? So there are many patients though, where the OR rod may not be present, even though it is AML. But if you see the OR rod, it is AML. So it is a pathognomonic presence of OR rod is equal to AML, but absence of OR rod cannot rule out the AML. Even with absence of OR rod, you may have AML in many patients. Probably by my statistics, 70% of the patient they may not have clear cut OR rods in cytoplasm or blood or bone marrow smear. So think of something next. Any expert who worked in hemato-oncology, open for all. We are close to 30, but answer is only 3, 4. So not a good idea. You need to post more answers
Age.
in this group. Age is come, sir. Age is done already. Age, pediatric age group ALL, adult, middle and older age AML, or present absent. These two criteria is done. So do you think this only two criteria by which we get to know that this is AML and ALL, or are there any other criteria which differentiate it?
Uh, I
Sir,
think
maybe
lymphadenopathy.
One by one. Yes. Sorry, what's your comment?
Uh, Lymphoadenopathy is present in the ALL and in AML, lymphadenopathy is rarely present.
Okay, rarely present. Fair enough. Lymphadenopathy is more common in acute lymphoblastic leukemia, less common in acute myeloid leukemia. But I have seen the patient, those who have AML and have lymphadenopathy. But in general, yes, lymphoid is more present with the lymphatic system enlargement, probably liver, spleen, lymph node, tonsils, and other lymphoid organs where the lymphoblastic leukemia, these are more common. What else? Yes, last but not the least. So let's go to the head-to-head comparisons of AML versus ALL, which brings more clarity to you and me. So ALL, acute lymphoblastic leukemia, AML, acute lymphoblast myeloid leukemia. One thing is common, acute leukemia. So first of all, you need to, there are three words, acute. This applicable to both because here also acute myeloid, acute lymphoid. So definition of acute is short duration, short duration. So patient is well before 1 month. He is absolutely fine, moving around, doing job, enjoying life. But within 1 year, he gets down. Acute lymphoid means lymphoid series is involved. I'll tell you, no need to mug up. It's a matter of concept. And leukemia means blood cancer, leukemia. So here same thing, acute, short term it was fine. Myeloid means myeloid series is involved, and leukemia, L for leukemia. So here the only word change is myeloid and lymphoid. AML, ALL. So A and L is both. If you put it here AM, here AML. If you put it L, here ALL. Right? Acute short term leukemia. Here myeloid series affected. Here lymphoid series affected. If there is a more than 20% of myeloid series means myeloblast increase. Here the lymphoid series means lymphoblast more than 20% increase in blood or bone marrow. It is called as acute myeloid or lymphoid leukemia. So under microscope, you have to see more than 20% of the lymphoblast. Here the blast. Here you have to see more than 20% of myeloblast. Here the blast. So blast is present in both, but here the myeloid series blast present, here lymphoid series blast is present, and that is how it is differentiated from AML to ALL. So far clear, yes or no? At least I would like to have your little feedback, yes or no? I won't expect more, yes or no?
Yes.
Yes, sir.
One,
Yes.
wonderful, wonderful. So this is one criteria, basic concept. So whenever somebody tells you in your OPD, IPD or ICU, likely suspected acute leukemia, sometimes you cannot confirm na, on peripheral smear. Say for example, hemoglobin is 9 gram, total count is 70,000, and platelet is just 30,000. So you are suspecting count is increased and platelets are reducing, it is likely acute leukemia. So first diagnosis is acute leukemia, and to differentiate, do the bone marrow and find out acute leukemia, which acute leukemia. If you see under microscope, myeloblast 20%, AML, lymphoblast under microscope more than 20% ALL. That's it. That's it. Matter is over. That's it. You don't need to be a superman to diagnose acute myeloid and lymphoid leukemia. So this is the one differentiating point I told you, right? The first is the age, as we discussed, less than 1 year usually, right? Common presentation, and more than 10 years. AML usually in 60, but let me tell you, for last 10 years I'm taking right now 5 leukemias to 6 leukemias admitted under me in my hospital. 6 leukemias, most of them there are ALL, few are AML as well, right? So I'm seeing between age of 40 to 60 nowadays for last few years. So this range 60, this is from the book, but just for your knowledge, this is reduced, especially in India, right? This age is like 40 to 60 nowadays. Second differentiating point, WBC count is more than 50,000. Here also WBC count can be more than 50,000, right? CNS involvement at diagnosis is very common, very common, and that is why we do the CSF. CSF, we do the CSF. Those who are seeing the things, right? Pediatric patients, ALL, they admitted, you do the lumbar puncture and give the IT methotrexate, IT intrathecal methotrexate prophylaxis for the CNS. So CNS involvement is very common at the diagnosis. Here rare or no CNS involvement. So that is a differentiating point, right? So this is second thing. Here you see more than 20% of the lymphoblast. That is why lymphoid leukemia. Here you see more than 20% myeloblast. That is why it is a myeloid leukemia. All right. Cytogenetic or chromosomal analysis. Cytogenetic in ALL, you can see 30% of the patient present with the Philadelphia chromosome, which is also seen in CML, just to brush up your knowledge. So it is so Philadelphia chromosome 922 translocation not only seen in CML. So in CML, you can see in more than 95% of the patient. In ALL 2 category, ALL 30% in adult and less than 5% in pediatric patient. So Philadelphia chromosome is present in CML and CML and ALL, which is not present here, which is not present in acute leukemia. You cannot see it, right? What you see here is commonly various translocation. One of the most important is will guide you, right? And immunophenotyping, right? So immunophenotyping is the most confirmatory test for leukemia. So there are four questions. Let me have one new slides for you guys. So you better understand. This is new slide for you. So for any leukemias, when the leukemia comes into the picture, right? Leukemia, right? When there is a leukemia, four options are same, right? CBC, peripheral smear, cytogenetic, immunophenotyping, or flow cytometry, right? Or bone marrow examination. Options are same. Four question. What is the most initial test for acute leukemia? Question number one. What is the diagnostic test for leukemia? Question number two. What is the confirmatory test for leukemia? Question number three. What is the prognostic test for acute leukemia? Options are same. Options are same, but there is a four questions. I will tell you. I will tell you just to save the time. Initial. So whenever patient comes with 9 hemoglobin, 50,000 of white blood cell and 30,000 of platelet count, right? In that case, the initial test options are initial test is CBC peripheral smear, initial test is cytogenetic, initial is immunophenotyping, or initial is bone marrow. So if they are asking you this answer change in all four. Initial test whenever you do the history physical examination. After that on suspected case you do the CBC. CBC you see and peripheral smear you look for two things. Look for the blast cell, look for the OR rod. If OR rod is present, AML. If blast is more than 20%, it is acute leukemia. Right? If the lymphoblast look in peripheral smear, it is acute lymphoid leukemia. If it is myeloid, it is acute myeloid. So by CBC and peripheral smear, 90% of the idea you will get it from the CBC and peripheral smear. And let me tell you, peripheral smear is nowadays people are very less performing because people are interested in hi-fi investigations, but they never bother to look under the microscope what is going on in the all three cell lines in peripheral smear, which supposed to be a tongue-shaped peripheral smear ideally. So here you can see hemoglobin means erythroid, myeloid, and megakaryocyte or WBC, RBC, platelet, everything you can see in the microscope. That you can have in the report of CBC, complete blood count, you have everything. You have indices, you have everything. Whatever you need to diagnose anything, it's under CBC. But we never bother and looked into it detail. So now one must look into detail. And if your pathologist is not giving peripheral smear, ask for the peripheral smear now onwards for every hematology patient, irrespective leukemia, lymphoma, myeloma, aplastic, MDS, sickle, thal, whatever you name the disease, ask always for a hematology problem, peripheral smear. Without peripheral smear, CBC is absolutely incomplete. So you just see whatever the strip you see is like CBC, run report in auto analyzer, right? You see the auto analyzer run report, CBC. You never see what is the they have to report like this WBC series, how it looks like under microscope, red blood cell series, and platelet, how it looks like. Here they need to see two things. What is the number of WBC and what is the morphology? Here, what is the number? What is morphology? Here, morphology number. Platelet number 150,000 number. Morphology platelets are normal in size and shape. Here our red blood cell, right? Number is 6 million and morphology is microcytic, macrocytic, inclusion bodies, fragmented RBCs, blah blah blah. I can take one lecture on peripheral smear, but just general idea, right? So that's it. So this is so when they ask you the initial test, it is CBC. So here the answer is CBC, initial test. This answer will change. If they ask you what is the diagnostic test for acute leukemia or suspected, four same option. Diagnostic test is CBC, cytogenetic immunoflow or bone marrow. Answer is bone marrow. You do the diagnosis by bone marrow biopsy by acute myeloid or acute lymphoid leukemia. What is a confirmatory test? 100% you want to confirm, right? It is myeloid leukemia only. Sometimes this leukemia you cannot differentiate even on the bone marrow because the morphology is so altered or dicey that it is sometimes difficult to see under microscope and tell you the exactly that this is myeloid or lymphoid. In that case, you need to do a confirmatory test that is called as a same option. Confirmatory test is CBC, cyto, IPT, bone marrow. Answer is immunophenotyping or flow cytometry. Have you heard of this CD marker? CD marker, cluster differentiation. CD is cluster differentiation. So God has given the excellent, this creature or excellent, this genetic profile on each and everybody. So every myeloid cell has their myeloid CD markers, lymphoid has their lymphoid CD markers. In lymphoid, there are two CD markers. T lymphocyte it's different, B lymphocyte it is different. So I'll going to come on that point as well. So this CD marker is unique for myeloid and lymphoid, and by immunophenotyping will guide this. So you never, whatever they are undifferentiated or you can diagnose or not, immunophenotyping 100% confirmed by doing right immunological molecular profiling, and they can differentiate this is AML and ALL, and you can differentiate subtype as well. AML has 8 subtype, M0 to M7, 8 sub including M0 is 1 and another 7, total 8 subtype. And lymphoid there are 3 subtype, L1 L2 L3, and here M0 to M7. So here 8 subtype, here 3 subtype. That also can be confirmed by the immunophenotyping. So answer is immunophenotyping. And prognostic test for acute leukemia, CBC, cytogenetics, immunophenotyping, or bone marrow biopsy. Diagnostic is cytogenetic. So if you can see here, all the answers are different. Here cytogenetic, confirmatory test is immunophenotyping, diagnostic is bone marrow, initially CBC peripheral smear. So in one question, what they ask, you need to answer depends on what they ask, right? So this is logic, this is basic, this is basic concept. So now you are absolutely expert in this. I don't think you will going to repeat the mistake in the exam. You need to just look into the questions, what exactly they are asking. Initial, diagnostic, confirmatory, prognostic, that's it. Though there is a same options, all four options are same, but I explained you crystal clear how it differentiate from other. Prognostic means there is some kind of chromosomal abnormalities, and this chromosomal abnormality will decide, right, in three category, whether it is a good risk AML or ALL, it is intermediate risk AML, or it is a poor risk or high risk AML, right? And depends on that why you need to know the cytogenetic or prognosis. Depend on that you need to decide the treatment plan for hematologist, whether this patient will just going to help with the chemotherapy, or they need a transplant in future, or after induction chemotherapy, or once the bone marrow in remission after one dose of chemotherapy, do they need bone marrow transplantation or not. That depends on this, and that is why it is mandatory. And on day one we need to do all four. So I do all four. I will share one report of my patients of initial is like, right. So you can know that how initial test, it mentioned initial bone marrow. I did it 5 in last 5 days. Diagnostic, immunophenotyping I'll share you, and cytogenetic I'll share you. Right. So you get to know how we diagnose initial, diagnostic, confirmatory, and cytogenetic, and how it is important for every leukemia. Is that clear to everyone? Yes or no?
Yes, sir.
Sir.
Is that clear to everyone? Yes or no?
Yes, sir. It's clear, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Sorry?
Yes, sir.
Wonderful. Any questions so far? Any questions so far? Lot of doubts will be cleared today anyway. All right. So you keep your doubt, get noted in your the copy. Will solve your queries. Now this without understanding this picture, you never ever understand any leukemias. So I already told you this is a mother cell. Mother cell is stem cell. Stem cell is mother cell, and this mother cell or stem cell, sorry, this is mother. I can say mother cell because from here everything produced. So two things produce. One is a myeloid. Myeloid. When there is a myeloid leukemia, something wrong in myelo, and this is lymphoid. Just remember in a simple way, myeloid and lymphoid, right? There are a lot of things or cells in between, but I'm just giving you the concept, right? So let me draw you the more simple definition for you. So you can remember forever. So hematopoietic stem cell. hematopoietic stem cell. So this is a stem cell. Stem cell. Stem cell will give rise to two blast, myeloblast, and another is a lymphoblast. Blast is also there in our body, but it is in normal, just for your knowledge, less than 2%. So Dr. Munjal, if somebody does my bone marrow, there is a less than 2% of lymphoblast and less than 2% of the myeloblast. This is normal. But when this abnormal increase from 2 to more than 20, it is lymphoid leukemia, it is myeloid leukemia. Simple. So blast is present in normal individual, but it is there like hemoglobin. Hemoglobin is present in your body and my body. This is 13 to 15 minimum. If less than 13, anemia, more than 15, polycythemia. Same, right? We have a stem cell, and because of stem cell, we produce all blood cell. So we have a stem cell, we have a myeloblast, we have a lymphoblast, but which is within normal limit. If it is more, then it is acute lymphoid, acute myeloid. Moving further, myeloblast will give rise to all cells. So what cells? Simple. One is RBC, means red blood cell. Another is a platelet, and all WBC except lymphoid. So what four cells? Neutrophil, eosinophil, basophil, monocyte. This is developed from the myeloid cell, and lymphoid blast lymphocyte will develop. Lymphocyte. So there are five WBC differential. Out of five, four develop in myeloid, only one develop in lymphoid. This lymphocyte, there are two types, B lymphocyte and T lymphocyte. And last, in less number, natural killer cell. But don't worried about this for now. Just B lymphocyte and T lymphocyte. Right? So every cells can be differentiated from the CD marker, cluster differentiation, right? By flow cytometry, right? So this is the basic, absolutely basic. So if there is a neutrophil problem, eosino, baso, mono, platelet, or RBC, right? It is a myeloid leukemia, and if it is a B or T lymphocyte, if it is B lymphocyte is more in lymphoblast, then it is called BALL. This is how we do clinician. B cell acute lymphoblastic leukemia, T cell acute lymphoblastic leukemia. So BALL, TLL. So in ALL, two category. You can ask, right, while you are in the round, whether it is B or T. If it is not differentiated, go and do the flow cytometry. Flow cytometry will differentiate B and T. I'll tell you how to differentiate in next slide, right? So this is what the thing is, and here depends on this what and at what stage and what maturation they develop. L1, L2, L3, three type of, and what involved is red blood cell, platelet, or which cell. Here M0 to M7 subtype it develop. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Yes, sir.
Yes,
Any
sir.
confusion?
Yes, sir.
Hope it's clear, isn't it?
Yes, sir.
Wonderful. Wonderful. Let's get back to this picture, original picture. I did little modified version or easier version for you guys. So here hematopoietic stem cell, here myeloid cells, here lymphoid cell. I told you myeloid cell, RBC, red blood cell develop, platelet develop, I told you, and four type of cell, one, two, three, and four. Lymphocyte is not produced because lymphocyte is different lineage. So this is myeloid and this is lymphoid. So in lymphoid, lymphoblast and lymphoblast B lymphocyte, T lymphocyte, that's it, khalas. Is that clear to everyone?
Yes, sir.
Any doubt?
Yes, sir.
If you understand this tree, you are expert. You are expert, believe me, because you can answer any questions. Why? Because you know the concept now. We never know the concept earlier, so we are struggling, right? So this is concept, right? So move little further, right? So this questions was AML or rod, initial diagnostic, confirmative prognostic. I already told you this is myeloblast versus lymphoblast. How you see under microscope? Though we discuss two more less questions, it's fine, but you understand. It is so complex, but I'm trying my level best to make it most easiest. Right? We'll take 2, 3 lectures of hemato, but we'll finish it, but concentrate on the things. So myeloblast is larger. You can see in the picture. It is under microscope. When you see the peripheral smear, you get it. Cytoplasm. So what is cytoplasm? This is cell and this is nucleus. So this all space is called cytoplasm for your knowledge. So here you can see cytoplasm is very, very less. You can see the cytoplasm very less. This is red line thickness is cytoplasm. See here the cytoplasm. So more space between nucleus and cell membrane. More space. You can see it clear cut. So here cytoplasm is moderate, here scanty. Or rod may be present. See here may be present, not 100% present. May be present. But if it is present, it is AML. Here you can see the pin-shaped structure in the cytoplasm. If it is present, it is called as or rod, and if it is present, it is AML. One line definition of ALL is presence of or rod, which is absent here, right? Nuclear for chromatin. Nuclear chromatin is fine. You can see fine nuclear chromatin. Here, here course dot its course. This is size, so we don't need to remember this, right? What is micron and all blah blah. So this is microscopically basic things. What they are the larger in shape than lymphoid. Cytoplasm is more than lymphoid. Or rod if present, it is AML, and chromatin is fine here course. Is that clear to everyone? Yes or no?
Yes, sir.
Yes.
Wonderful. So this is the head-to-head comparison between myeloblast and lymphoblast. So this is questions. This is our picture, AML, ALL. This is um, concept. This is how they evaluate, and this is what the thing is. So this is again OR rod. I mean, I'll forget to tell you. This is OR rod. You see, this is a cell. This is a cell, and within the cell, there are many rod-like structure here. Let me change the color. This red. This is rod or pin-like structure. So one single is OR rod. There are multiple OR rod. Multiple. The name change. It is called as a faggot. 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 So OR rod is single OR rod. It is situated in the cytoplasm. Single, it is OR rod, but in cytoplasm there are too many OR rods. It is called faggot. So this is classical for M3, M0 to M7 subtype. M3 is most commonly seen faggots in M3, acute promyelocytic leukemia, right, which carries the best prognosis amongst all AML M0 to M7. So that is a concept. So this is OR rod. Now again AML, ALL, it's not just finished. How you differentiate, again, very, very important differentiating point. So immunohistochemistry, right? By immunohistochemistry, you can differentiate. Simple, we write down here ALL and AML. So myeloperoxidase, right, is negative, here positive. So this is again a very important chemistry or biochemistry or cell chemistry, you can see. So you can ask for the cytochemical staining, or you ask for the myeloperoxidase enzyme. If it is present, myelo means myeloid, myeloid. So MPO, shortly known as myeloperoxidase. So it is absent in AML, but M for myelo, M for myeloperoxidase, M for myeloid. So easy to remember. Myeloperoxidase present means myeloid leukemia. That's it. Flow cytometry, I told you. So in flow cytometry, you find the CD markers. So in CD markers in ALN and AML and ALL. So in CD marker, there are two categories, BALL and TALL, and in myeloid there are M0 to M7. So in myeloid leukemia, CD 13, 33, 34, 117, it's present. It is written here. And B lymphocyte and T lymphocyte, CD 10, 19, 20. And I remember this as a 238. So CD2, CD3, CD8. It is all CD. That's it. So this is how you differentiate. That's it. This is what the flow cytometric gives you in the reports of the patient, right? So you need to know. You don't need to remember all this, honestly speaking. But if you remember it, great. It's great. Believe me, right? And this report absolutely give by the hematopathologist. You don't need to do what I do. I am not reading this. What I'll do bone marrow, and I ask for the four tests: bone marrow aspirate, bone marrow refined, bone marrow cytogenetic, and flow cytometry. I ask for this. So this will report will come in 24 to 48 hours, and they mention this all: how much blast, how much CD marker, what is present amongst all CD markers, and what is present, MPO present or not, right, or absent. And they give you the final report that this is acute myeloid leukemia, M4 subtype amongst M0 to M7, right? And this myeloid, so CD13, 33, 34 is present and MPO is positive. That's it. This is what AML reporting is done, right? Cytogenetic, I already told you, Philadelphia chromosome is present in ALL, not present in AML, and molecular tests are also there. Not going much in detail of that. So this is what the thing is. So this is myeloid versus lymphoid, and myeloid lymphoid B versus T lymphocyte, and this is one picture. It is not available in any book in the world. Believe me, this is I created on my experience and my hematologist experience. So this chart will completely give you complete clear cut idea about all four leukemias in one slide. One slide, all four leukemias. AML will go very quickly just to rehash, maybe probably little bit, but it's important. I'm repeating, more than 20% of the blast, but it is myeloid blast. ALL more than 20% of blast, but it is lymphoid blast. CML usually no blast. It is not in chronic leukemia. There is less than 20% blast. For your knowledge, less than 20%. More than 20%. If you see more than 20%, then it is acute leukemia. Less than 20% chronic leukemia. That's it, right? So here no more than increase, here no more than. Let's see AML, acute myeloid leukemia. How do they present more than 20% of myeloblast? CBC, either there is an increased WBC count or there may be a pancytopenia. Thrombocytopenia is the most striking features amongst all four. So right, so thrombocytopenia is the most striking features in AML, which is less common in ALL, CML, CLL. OR rod is none other than AML. So OR rod is not seen here. No OR rod, no OR rod, right? No OR rod. So OR rod is not seen in ALL, CML, CLL. OR rod is equal to AML. That's it. Faggot is present in, as I told you, faggot. What is faggot? Multiple OR rods in the cytoplasm is faggot. It is seen more in AML. You cannot see OR rods in all three. MPO, myeloperoxidase, and Sudan black is positive. Here negative in all. CNS involvement in AML is no. CML involvement is very common. That is why we give prophylactic methotrexate. No CNS involvement, no CNS involvement. Treatment induction followed by consolidation, or probably the stem cell transplant or bone marrow transplant, especially in high risk on cytogenetic. Prognostic test I already told you, and ALL induction, consolidation, and maintenance. Here no maintenance in AML, only induction and consolidation. Here maintenance we give usually with the 6 mercaptopurine and methotrexate, give for 2.5 years for all patients, adult or pediatric. So maintenance is there. Here no maintenance. Here treatment only none other than imatinib. Imatinib is tyrosine kinase inhibitor, which blocks the BCR-ABL oncogene, and by blocking this gene, you can stop the progression of the CML. So it is a drug of choice, and here chlorambucil and another chemotherapy, right? So and presentation. This is presentation. So how AML usually pancytopenia or high count, right? Thrombocytopenia striking features. Here pancytopenia, high count, but here lymphocytosis because it is lymphoid leukemia. CML classical is high WBC count, neutrophilic leukocytosis, and splenomegaly, massive splenomegaly is the striking features. And CLL, chronic lymphoblastic leukemia, also there is a leukocytosis. Among this leukocytosis, there is increased lymphocyte because it is lymphoid leukemia. Hepatosplenomegaly and lymphadenopathy is very common here, and ALL, but not in AML and CML. So that's all for all head-to-head comparison in general, right? For your understanding how you differentiate one from other, right? So that is very, very important, right? So that differentiate from AML to ALL. Any doubt, any questions so far?
Sir, flow cytometry, immunochemistry is the confirmatory test for all four?
No. Confirmatory test is only one globally, is immunophenotyping, which gives you the genetic makeup of the cell, and cytochemistry is just the test, but it is not a confirmatory test for any leukemia. It gives you the idea. If MPO positive, it's AML. If MPO negative, ALL. But it is not 100% sensitive and specific than flow cytometry. So flow cytometry is 100% confirmatory test versus AML, ALL, and M0 to M7 versus L1 to L3 subtype as well. So by flow cytometry, you not just get the diagnosis, you get which subtype is there from M0 to M7, which is not which cannot be tell by immunochemistry. Is that
Thank
clear?
you, sir. Thank you, sir. Yes.
Okay. Any other question? Any other question? Fair enough. No questions, Mel. I'll go ahead. Second question, 29-year-old woman, you get your gather your I'll give you some today I'll give you opportunity to ask your queries. 29-year-old woman complains of tiredness, especially during the activity. On examination, patient appears pale or rod and cystocytes can be seen on peripheral smear. The patient is referred for bone marrow and extracted. The cells are sent for the cytogenetic. This is the cell or rod is seen, but what they ask is right they send for cytogenetic analysis. Most likely result of the cytogenetic analysis is what? Translocation 12, 21, 15, 17, 9, 22, 14, 18, 18, 14, 18, 8, 21. What translocation you can see? So this is AML patient 100% or rod is equal to AML. We learned it, so don't get confused. They have given the or rod. So this is, if you make a triad of this, what is the diagnosis? Diagnosis is AML. We did it, right? Diagnosis,
Yes.
investigation is bone marrow and flow cytometry, right? So investigation, one of them is cytogenetic. So what cytogenetic abnormality you can expect in AML in this patient amongst this cytogenetic abnormality? Yes, anyone? Let
D,
me
sir.
check.
D.
14, 18.
14, 18.
I
C is a Philadelphia chromosome.
Philadelphia. 14, 18.
Yes,
9,
Kasturi. What?
22.
Okay, fine. Yes, Kasturi. Let me come to the new guys. Yes, Kasturi. Please tell me. Don't hesitate to discuss. Yes, you will learn a lot of things. Yes, go ahead.
I think it's a translocation of 14, 18.
14, 18. Is that your answer, Dr. D? D for
Yes.
doctor is your answer?
Yes, sir.
Okay, fine. Let's see. What other comments. So I'll post your name as Dr. Kasturi's Dr. Kasturi here. D answer. Okay. Let me check what other people are saying. Yes, Sabnam. Dr. Sabnam, if you can speak up.
Yes, sir. Sir, I think it is C, translocation 922,
Okay, fine.
Philadelphia chromosome.
Fine. So far, did you learn anything that where I mentioned that 922 translocation is seen in AML? This is case of AML. Then don't forget it.
Yes, sir. Yes, sir.
Yes,
Right.
sir.
So AML, you cannot see 922, so that answer is wrong. Right? Let me tell you, 922 translocation, I already told you in earlier slide, it is seen in CML. In 95% of the plus patient, you see translocation 922. And in ALL2 category, in pediatric, 5% in pediatric patient where you see the translocation 922, and 20 to 30% of adult patient with ALL where you see. But in AML, you cannot see translocation 922. So this question option is gone. This answer is wrong. Now go ahead. Think about the options. Yes, Dr. Mariam. Any comment? Don't expect every time the lollipop questions in the exam. Sorry. Yes. Anyone? We are more than 30, 40 doctors now in the group, and only answer is 5, 6. That's it. Otherwise, I'll speak up the name. Yes,
It's
Dr.
B,
Chandra
sir.
Shiri. Yes, which? Think, apply your brain. God has given us nice brain. So I will tell you all six where you can see all six, right? So answer is 15, 17. So mug up or remember. Translocation 1920, the gene or abnormal gene or oncogene develop is BCR-ABL, right? So one part of BCL, right? 22 and ABL 9, they translocate and develop one gene that is called as a Philadelphia chromosome, and drug of choice is imatinib. Multiple question in one line. Where you see CML, 95% of patient, less common in ALL, but it is there. 5% of pediatric patient and 20% to 30% in adult patient. So it is seen in CML and ALL, not in AML. Our question scenario is AML. Why? Because we say or rod, and or rod is equal to AML. So our patient is not a CML, not a CLL. So those who have given the answer T92 is wrong. It is seen in CML, ALL, not in AML. Dr. Sabnam, is that clear? Yes or no? If not, then clarify right away.
Yes, sir. Yes, sir. I got it.
Wonderful. So T92 is solved. Second is somebody answered translocation 1814. Why? Because it is 1814 is there in the option D. So 1814 is seen in Burkitt's lymphoma. Remember, they will ask you amongst which lymphoma you see 18, 20, 14 Burkitt's lymphoma. Stretch yourself bit, but remember this six translocation. 1418 is there. It is seen in the follicular lymphoma. 1418 follicular lymphoma, right? 1114 it is seen in the mantle cell lymphoma, right? And another important 1517 is seen in acute promyelocytic leukemia, AML M3, right? Acute promyelocytic leukemia, and the oncogene is called as a PML-RAR alpha. PML-RAR alpha. Like CML, the oncogene is BCR-ABL, here PML-RAR alpha. It's translocation between 15-17, right? And the drug here, the imatinib, which blocks the BCR-ABL, here the drug which blocks the PML alpha, RAR alpha is ETRA, all trans retinoic acid, all high yield questions in the exam. One slide will give you 20 questions. So ATRA is the drug of choice, right? And translocation 1122, Ewing's sarcoma. So these are the few common here, right? So this all you can see it, right? All you can see it. So this slide will be very helpful for you, right? So this all right. So here the answer is translocation of 15, 17. Those who has given the answer B is the correct, because this is AML. AML or rod is common in AML M3, and AML M3 there is a translocation of 15 and 17, and this translocation of 15 and 70 oncotype gene is PML RAR alpha. You go and read it now from Master the Board or from our website. Everything is given, and drug of choice which blocks this is ATRA. That's it. So either they ask you AML, one question, which is where the OR rod is seen commonly, AML M3, which translocation, third question, 1517, which oncotype gene develop PML-RAR alpha, which drugs blocks this oncogene, etc. So in one line, there are 5 questions. Amazing. Is that clear to everyone? Yes or no?
Yes, sir.
Yes,
Is
sir.
that clear to everyone? Yes or no?
Yes, sir.
Yes,
Yes,
sir.
sir.
Wonderful. Only your yes will motivate
Is
me.
there
So
any mnemonic to remember these numbers, sir? It is very difficult to memorize.
I need to make it honestly.
Thank you, sir.
Give me some time. But shortly, you cannot afford to miss two things. One is AML, you must remember it, 1517, and CML 922. At least you can remember these two. Don't say no. because this is very high yield MCQ in every exam, every exam. So I'm not going in detail. I already told you whole the story, blah blah blah, what is going to be there, right? DIC is seen in which of the following type of AML or acute myeloid leukemia? There are 7 subtypes: M3, M4, M2, M5. So first of all, one question. DIC means disseminated intravascular coagulation is commonly seen in which of the following subtype of AML? M3, M4, M2, M5. And there are another 6 questions. Best prognosis among all AML, which subtype? Commonest AML amongst the subtype means M0 to M7 is subtype. I will tell you what all 7 subtypes are there, right? But just for your knowledge, M0 undifferentiated, M1 minimal differentiated, M2 well differentiated, M3 acute promyelocytic leukemia, M4 myelomonocytic leukemia, M5 monocytic leukemia, M6 erythroleukemia, M7 megakaryocytic leukemia. That's it. I remember, that is why I wrote it immediately. This is all M0 to M7 subtype of AML, which is classified by FAB, French, American, and British. So these are the people who has given, and it's same thing for WHO. So by and large, the classification is same for WHO, and for many years you need to know. So whenever you diagnose AML, so first diagnose AML, and then you need to write down next step is AML M3 subtype, like Hodgkin's lymphoma, and diagnose classical Hodgkin's lymphoma. Non-Hodgkin's lymphoma subtype is diffuse large B cell lymphoma or follicular lymphoma or mantle cell lymphoma or Burkitt's lymphoma or natural killer cell lymphoma or peripheral T cell lymphoma, blah blah blah. There are long list. Just for your clarity, I mentioned few names. So you need to diagnose first AML, right? That you can diagnose by bone marrow as well if it is well differentiated, and M3 by flow cytometry. So you need to write down complete AML M3, AML M2, AML M0, AML M7, blah blah. So what they are asking, this is concept I had given you now. So DIC, disseminated intravascular coagulation, is seen in the which of the following subtype of AML? Means your options are M0 to M7. So decide where it is common. One question. Now options are same for all 6 questions. Options are same for all sub 6 questions. Best prognosis amongst all AML, which subtype, right, has a best prognosis? Which subtype is most commonest? Which subtype has a DIC, which is our questions? Which subtype, how to categorize AML by risk factor? How to treat high risk AML? What is the ATRA and where it is used in AML? So there are several questions, hundreds of questions on AML in exam, and they ask, believe me, they ask. These are not very hi-fi or tricky or super specialist exam. They ask you frequently, right? So this is the classification I told you, right? So there are questions we will solve from this box. So undifferentiated, minimal differentiated, different. I told you all 7 names. So most common. So if they ask you the most common out of 100 patients, which patients are maximum of AML M0 to M7? So M2 is the most common. Out of 100, 30 patients are AML M2. So if initial test, diagnostic, confirmatory, prognostic, like AML here, different. Most common AML M2. Best prognosis, if they ask you the best prognosis, best, which has the highest cure rate, this 80% patients are cured. So having AML M3 is a good thing because their prognosis is best. 80% of them they are cured. But if you ask the statistic, how many patients are developed AML M3? 5% among 100. This percentage is among 100%. So highest is AML M2 or most common is AML M2. But if best prognosis or highest cure rate, then answer may change. Most common is not highly curable. They may be bad, right? So look at the question in the exam. So best prognosis AML M3, right? Second, which AML is least common? Most common, least common. M7 is the least common. M7, M6 as well, but M7 is the rarest of the rare. Honestly, speaking, in 20 years, I've seen only one patient of AML M7, right? M0 to M5, I've seen plentiful and I'm seeing every day. M6, M7, M6, I'm seeing probably once a year, but M7, like in 20 years, I've seen one only. So they are absolutely rare of the rare AML M7 and carrying worse prognosis, believe me, and carrying the worst prognosis as well. That is question in exam, right? Which AML has the DIC presentation? Answer is AML M3. So AML M3 present with DIC. AML M3 has a highest cure rate of 80%. AML M3, which AML has drug, right? Which AML M0 to M7 will help with ATRA drug. So AML M3 help the ATRA drug because in M3 you see a translocation between 15 and 17. Oncogene is PML RAR alpha, and PML RAR alpha is blocked by the ATRA all trans retinoic acid, that is vitamin A derivatives, which blocks this gene, which drugs the progression of the AML M3, and it is a drug of choice along with the chemotherapy. So this is the high yield for M3. You need to remember for M3 three things. DIC most common, highest cure rate. ATRA will act on this. That's it. M3 three facts you must remember for M3, right? So here for the answer point of view, right? DIC is common in which subtype of AML? It is answer is M3. M3 acute promyelocytic leukemia, right? Which helps the progression of the neutrophil maturation. So we'll see sometime in detail pathophysiology, but this is the answer. Is that clear to everyone? Yes or no?
Yes.
So we
Yes,
answered
sir.
seven question in one slide. DIC M3, base prognosis is M3, commonest AML is M2, DIC common presentation is M3. Question 4, how to categorize AML by risk factor, right? So you can categorize how to treat high risk AML. So high risk AML can be treated with induction followed by bone marrow transplant. And what is ATRA? ATRA is all trans retinoic acid, vitamin A derivatives, and it is used in AML M3. Is that clear to everyone? Tell me at least yes or no.
Yes, sir.
Yes.
Yes, sir.
Wonderful. So go and revise it. My class as well as book. Now you think you collect lots of things because now you remember the basic. So I answered all six questions, right? This is CML questions once again, right? So exactly what comes, Philadelphia chromosome refers to what? Long arm of 9 and long arm of 22, short arm of 9 and long arm of 22, short arm of 9 and long arm of 22, and long arm of 9 and short arm of 22. So how the Philadelphia chromosomes develops? In 922, there is a translocation, but which arm goes to which arm goes to which arm, 9 and 22, short and long. So four possibility, and there are eight another questions, right? How you diagnose number one, BCR-ABL seen in which other condition, which drugs blocks BCR-ABL oncogene, how many percentage of patients has BCR-ABL positive in CML, how many phase of CML, how to treat blast crisis of CML, how many percentage of people have Philadelphia positive in CML, and which deficiency, which vitamin deficiency common in CML patients. So in one slide, at least nine questions. I can make 20 questions, but at least nine, it's absolutely visible here in one slide, which will finish all 10 questions in next 1 or 2 minutes. Yes, anyone hematology guy or interested like me in hematology, please answer. There are pathologists in the class as well. What I remember, probably two, three pathologists are sitting there in the class. So what's your opinion? How you treat in your premises and how you treat and diagnose and differentiate? Yes. Anyone? If you shy, you can post the answer in the chat box. But you need to answer because you will remember me in exam room because this all will you can see in front of your screen. Believe me. Out of 30, 40 doctors, only one answer. Two answer. Yes, Dr. Jabahar, what do you think what went wrong?
And I think it's long arm of chromosome 9, one gene is
So both are long
translocated.
arm of 9 and long arm of 22, right? That
Oh,
is what
sorry,
you say.
sir. Both are not
It's a
long
long
arm.
arm of chromosome 9 and the short arm of chromosome 22, I think. It's a
Because
translocation.
A means both are long arm. Fine.
Okay.
So first of all, let me clarify you what is long arm, what is short arm, what is 9, what is 22. So first of all, concept clarity. I love concept clarity first. First normal you understand, then abnormal easy to understand. So this is normal chromosome. You and me have all 23 pairs of chromosome, right? So if you see the cytogenetic, there are 23, right? One, they are in pair. So this is called one, right? Like that, there are 23 pairs, means 26 number, total number 46, but pair is 23, right? And 23rd pair is called as a sex chromosome. In male, it is XY, and in female, it is XX, isn't it? Yes or no? Yes or no?
Yes, sir. Yes, sir.
Wonderful. So there are 23 pairs. Amongst there is a something wrong in the number 9 and something wrong in the 22. So remember, this translocation means one part of chromosome is going to other part of. So translocation shortly in medical write as a 922, means there is a translocation 922. Translocation 1814 means translocation in number 8 and number 14. Translocation APL M3 1517, right? Translocation between 1517. So in CML, there is a translocation in 922. So chromosome 9, this is long arm, this is short arm. This is chromosome 20, right? This is short arm, this is long arm. This is short, this is long. In the 9 number of chromosome, normally you and me have ABL gene, and on 22 you have gene of BCR. So normally BCR ABL is right there located. So ABL is located on chromosome 9, BCR is located on chromosome 20. In your chromosome, in my chromosome, in normal. This is normal. What is abnormal? I'll come to abnormal after explaining you the normal. So what happens in Philadelphia chromosome, right? Some portion of ABL, you can see here the ABL portion. So some portion of ABL, right? And some portion of BCR, right? So some portion of ABL and some portion of BCR will translocate from here to here and from here to here. And they will create one new chromosome, and this new chromosome is called as a Philadelphia chromosome, where you see the BCR ABL. In your body and my body, you cannot see BCR ABL together. You can see ABL on chromosome 9, you can see BCR on chromosome 20, but you cannot see in one chromosome both the things, BCR and ABL. When you see the both chromosome in one together, ABL and BCR, it is called as a BCR ABL oncogene, right? And this
Maybe
oncogene is derived by the TKI. There is an enzyme called tyrosine kinase inhibitor. This tyrosine kinase inhibitor helps to grow this BCR, and to grow BCR means you are growing or progressing the CML. So logic is that if you block this tyrosine kinase inhibitor, you are blocking the BCR ABL, and B, you are blocking the CML growth and progression. And to block this TKI, tyrosine kinase inhibitor enzyme, there is drug invented 20 years back. The name is imatinib. So imatinib is a tyrosine kinase inhibitor drug. This tyrosine kinase inhibitor inhibits the BCR-ABL. It acts at this molecular level. It will not allow the BCR-ABL to happen. And when BCR-ABL is in your body, if you have BCR-ABL in your body, means your WBC is 10,000, 20,000, 30,000, 40,000, 50,000, 1 lakh, 2 lakh, 3 lakh. uncontrolled overgrowth of the white blood cell because of this BCR-ABL gene. If you block this gene, you are blocking this whole system and you help CML under control. Is that clear? Yes or no? At least tell me yes or no.
Yes.
Yes or no?
Yes, sir.
Yes, sir.
Wonderful. Wonderful. So this is
Yes, sir.
chromosome, Philadelphia chromosome. So Philadelphia chromosome is abnormal mutated chromosome. So whatever the numbers, if you have seen 500 chromosomal analysis, and if you see in the 250 cells BCR-ABL means 50% of the gene or karyotype has 50% of these things. Every chromosome may or may not get, but you need to count. It is the job of geneticist who is doing the Philadelphia. I will share this report as well. 2 days back, we diagnosed one CML 922 translocation in cytogenetic and BCR-ABL almost 50%. So I'll share one report with you as well in the group. Right. So this is Philadelphia chromosome. So Philadelphia chromosome, right? So Philadelphia chromosome is this, and there are another questions. Diagnosis of CML, will see it. So diagnosis of CML is very easy. Three things in one line. If you want to diagnose CML, look at the three things. Middle-aged patient, middle-aged, less common in pediatric patient. High WBC count. Amongst this, neutrophilic leukocytosis, because it is myeloid series. Remember the myeloid series, stem cell, myeloblast. Myeloblast, three things: red blood cell, platelet count, and myeloid series, neutrophil. So neutrophil, eosinophil, basophil, monocyte. Only lymphocyte is not there because it is produced by the lymphoblast. So neutrophil is in myeloid. So myeloid leukemia, myeloid. So neutrophil is usually increased. Is that clear? Yes or no? So myeloid series neutrophil is increased. BCR-ABL seen with other condition. Second question, CML obviously in 95% of the patient. Positive and pH positive ALL, 5% in pediatric patient and 20 to 30% in adult patient. Which drug blocks the BCR-ABL gene? Drug name is imatinib, and new drugs comes in the picture, dasatinib and nilotinib. All three are TKI, tyrosine kinase inhibitor drug. It's a group of drug. First generation cephalosporin, second generation cephalosporin. Like that, this is TKI, tyrosine kinase inhibitor. There are first, second, third generation, but we are not going to go in detail right away. So, but just for your knowledge, it's a group of TKI drug. How many percentage of the patient BCR-ABL positive in CML? So 98% of the patient have BCR-ABL positive. How many phase of CML? There are three phase: chronic phase, which is present in 95% of the patient; accelerated phase, which is present in 5% of the patient; and worst phase is the blast crisis, which is present in 1% or less than 1% of the patient. And how to treat the blast crisis in CML? How to treat blast crisis? Blast crisis treated with a drug, right? Same drug like all these three: imatinib, dasatinib, nilotinib. And when they progress on this, allogenic bone marrow transplant as quick as possible in most of the patient. And how many percentage of the people have Philadelphia positive chromosome in patient? 90% have pH positive, 10% has pH negative. But those who have pH negative, you ask for BCR-ABL, almost 100% of the patient have BCR-ABL positive. So you can diagnose by both way. First, ask for the cytogenetic. In cytogenetic, see for translocation 922, which is present in 90% of the patient, but 10% of the patient are there who have CML, but they have negative Philadelphia chromosome, or no translocation, but BCR-ABL oncogene is present, and you can give the drug same imatinib to them as well. And which vitamin deficiency is common in CML? Answer is vitamin D. So vitamin D is, by any unknown reason, it is very low. So along with CML, it's academic or research things. Vitamin D should be supplemented in CML. If they ask you vitamin A, vitamin B, vitamin C, or D, in four options in CML, which vitamin is deficient? A, B, C, D. Answer is D. Another question: which vitamin is very high level in CML. Answer is vitamin B12. That's it. So this is all related with the CML. These things, basic things. So you need to go and revise it once again. Then your picture would be very, very clear. So vitamin B12, I told you, right, elevated in B12. So I'm not going much in detail of this. So vitamin D is deficient and vitamin B12 is in excess level, right? So that is what the thing is. And this question is again uh, related with vitamin. So vitamin B12 level in chronic myeloid leukemia is elevated, decreased, normal, or markedly increased. So we have seen it. It's markedly increased because more WBC cell, more cell will have more turnover of B12. So B12 is increased. What decrease is vitamin D? It's decreased. Second question, manifestation of B12 on CBC and bone marrow. So if you have B12 deficiency, right, what kind of anemia you develop? Right? What classical picture of B12 in peripheral smear? They ask 100 times, right? And iron deficiency anemia versus B12 deficiency, how you differentiate? Other questions in one question. And what are the stages of B12? Just to cut short the time, right? The answer is, I told you already, B12 deficiency, vitamin B12 is high, vitamin D is low. So B12 is extremely high. There are four stages of vitamin B12 deficiency. Probably you never have heard. You probably mug up the things, but you did not. So four stages of vitamin B12 deficiency. What happens initially in stage 1? Decrease the level of B12. This is most common. This is you do in day-to-day practice. What we do, our test, we check vitamin B12 level. It is low. We are absolutely asymptomatic. So it's a stage 1. What happens? You don't treat at the stage 1. They will move to stage 2. Low level of B12 in your cells along with the metabolic abnormality. Metabolic abnormality will develop second. What third develop? Two things: neurological and psychological symptoms like anxiety is a symptoms of B12. So never ignore in your patient. Do it B12. If it is low, supplement it. Confusion, problem with the balance or neuropathy related things, balance, and many others. And stage 4, these are the common one. Stage 4, macrocytic anemia. So B12 related with the macrocytic anemia. Macrocytic anemia means increased mean corpuscular volume. Normal is 80 to 100. In iron deficiency anemia, it is less than 80. And in megaloblastic or B12, it is more than 100. Most important differentiating point. So macro means large. Large MCV means more than 100 MCV. Anemia means low hemoglobin. So increased MCV with low hemoglobin is called as a macrocytic anemia, commonly seen in B12 deficiency. Why it is large? Why not small? Because it helps to prevent the maturation of red blood cell because of B12 and folate deficiency, right? So iron deficiency is small RBC, B12 deficiency is higher big RBC is macrocyte, small RBC is microcytic, big is a macrocytic. So this is macrocytic. So these are the four stages of B12. You need to know what happens. And one more important things, right? B12 patients usually present to me for last many years either neuropathy stage 3 or either megaloblastic and pancytopenia. So they present with hemoglobin of 7, WBC count of 2500 and platelet count of 60,000. MCV is 110, right? So anemia with high MCV, anemia means anemia and high MCV means macrocytes. So macrocytic anemia, commonest reason is B12. This is the picture out of 199. I am seeing this, right? And I'll just need to supplement the B12. But because of pancytopenia, I don't want to miss the acute leukemia. So I do bone marrow and I'll see large red blood cell with no blast. Blast is leukemia, no blast B12. This is classical picture of B12, right? So let me draw you the picture for you. This is normal neutrophil. If you forget in your physiology in first MBBS, this is one lobe. This is attached with some filament kind of things. Two lobe. It is attached with the filament like structure. Three lobe. If it is granulocytic, there is granule in the cytoplasm. If it is agranulocytic, no granules in the cytoplasm. So granulocyte is neutrophil, eosinophil, basophil, or when there is a phil, It is a granulocyte, means there is a granule in the cytoplasm. Agranulocyte, like lymphocyte, right? It is a agranulocyte because there is no granules in the cytoplasm, and there are two agranulocyte, lymphocyte and monocyte, and cyte is a agranulocyte. That's it. So this is how five type of differential count. So this is the normal neutrophil which has three lobe. But when you have four lobe, when you have five lobe, when you have six lobe, when you have seven lobe, it is called hypersegmented neutrophil. Hyper means too much. Segment means this is one segment, two segment, three segment, seven segment. So hyper means more than three. Segment is this segment. And if you see the hypersegmented neutrophil, it is none other than B12 or folate acid deficiency. That's it. So here you can see count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Not too much. This is normal. 3, 4, less than 5. Ideally, hypersegmented more than 5 they count. Anything more than 5. So here not more than 5. 1, 2, 3, or max 4 or 5. That's it. So less than 5 nucleus. These are all red. It is seen is RBC. This is granulocyte. You can see the granules. So this is WBC neutrophil. This is RBC. This is small. Here you can see is megakaryocyte. So this is megakaryocyte or platelet. You can see platelet. You cannot see megakaryocyte in peripheral. So platelet. Sorry, right? So RBC, WBC, and platelet you can see in peripheral smear. If it is less than 5 nuclear lobe, it is normal. But if it is hypersegmented more than 5, it hypersegmented neutrophil, it is classical for B12 and folate. That's it. Is that clear?
Yes.
Yes, sir.
Is
Yes,
that
sir.
clear?
Yes, sir.
Yes or no? So last questions for today, and then we'll have little quick feedback. What is the single most accurate test for myeloma? Skull X-ray, bone marrow biopsy, 24 hours urine, serum protein electrophoresis, urine immunofixation electrophoresis, or presence of Ben Jones's diagnostic of myeloma.
Serum protein
D, sir.
electrophoresis.
Okay, you can post your answer in the chat box. I usually ask those doctors who have given the wrong answer to get the understanding what is in their mind. So you post your answer. I'll ask you. I can see each and everybody's name. So somebody entered as a CHA. Please tell me. You selected D, CHA. I don't know what is the full form of CHA. So those who entered and joined in the class as a CHA, please answer.
Look for the monoclonal proteins through serum protein electrophoresis.
Okay, so this is the absolutely wrong answer. Let me tell you, you will convince in 1 minute. Serum protein electrophoresis, what they ask is the most accurate test, most accurate test. So this is not a most accurate test. Why? I will give you example. Serum protein electrophoresis. You see the M band, usually M band. Are you getting me, Dr. CHA, yes or no?
Yes, yes.
Right. So M band is present in myeloma. M band is present in MGUS. M band is present in tuberculosis. M band is present in sarcoidosis. M band is present in autoimmune disease or mixed connective tissue disorder, right? And many other conditions. So how did you tell that this M band is because of myeloma? Why not MGUS? Why not TB? Why not malignancy also can cause false positive M band? Are you convinced with me or not?
Yes, yes.
So
Yes, sir.
M band, if M band is present, it is suspicious, not the diagnostic, not the most accurate. Initial test different, diagnostic different, prognostic different, confirmatory different. So same thing applicable to myeloma like leukemia. If they ask you initial test in myeloma, diagnostic test in myeloma, prognostic test in myeloma, confirmatory test in myeloma. So they are asking most accurate or confirmatory test, right? If it is M-band is in only and only myeloma, then this is accurate test, but it is not the case. I had given you the few general list of the test where you can see the M-band positive. So it gives you the suspicious but not the accurate. Is that clear to you? Yes or no? At least tell me yes or no.
Yes.
Yes.
Yes or no?
Skull X-rays.
I think it's a bone marrow biopsy.
Yes, anyone? Yes, Indu. Indu
Sir,
A.
yes, sir. Sir, in skull X-rays, in multiple myeloma, we see punched out lesions.
Okay, so let me give the explanation for this. Punched out lesion, right, can be seen in
Yeah.
myeloma. Punched out lesion can be seen in thalassemia. Punched out seen in many kind of hemoglobinopathies. Tell me now. Are you getting me?
Yes, sir.
So it is not the most accurate test. Call X-ray. And many a times, let me tell you, this is I'm doing 20 years. So that why I can give you complete transparent picture because I come across thousands of patients so far in my practice. And many times I see X-ray is absolutely normal. So if normal X-ray, that does not mean it is not a myeloma. Are you getting me? Yes or no? If some patient you did a skull X-ray, he has myeloma, but X-ray is normal. So you tell the patient, oh, don't worry, it is X-ray, your skull X-ray, epilateral is normal. You have no myeloma. Are you going to counsel in this way?
No.
Hindu, what's your comment? So these all are the supportive tests. The best test globally is bone marrow biopsy. More than 10% of the monoclonal plasma cell is myeloma. That's it. One line definition. Or rod is equal to AML. That's it. Like that only. One liner. Or rod is equal to AML. No discussion. Right? Presence of Reed Sternberg cell or RSL is equal to Hodgkin's lymphoma. No discussion. One liner. Presence of 10% plasma cell in bone marrow, multiple myeloma. More than 20% of the blast cell, acute leukemia. No discussion. This is golden lines. Golden lines. So whether X-ray is normal or abnormal, urine protein is present or absent, serum protein electrophoresis is M-band is positive or negative, urine electrophoresis or Ben Jones is present or absent. If you have more than 10% of the plasma cell in bone marrow, it is none other than myeloma. That is why it is the only diagnostic. Even though if you have serum protein electrophoresis positive, you cannot start the treatment. You need to do the bone marrow. Why? Because serum protein electrophoresis is present in TB, and in TB you don't need to give chemotherapy. You need to start AKT. Why? Because it is TB. Is that clear? Yes or no? So right? So first initial test is like CBC, peripheral smear. If you can see the plasma cell in the blood, you can see the low hemoglobin in 90% of the patient. You can see, probably see the word Role formation, Role formation. So one RBC on another RBC, one RB on another RBC. This is called Role formation, right? So it's like a collection of coins, one over another. It is called Role formation. So CBC, HB low, peripheral smear Role formation, right? Diagnostic is bone marrow biopsy, right? So bone marrow biopsy, prognostic is cytogenetic, confirmatory is also bone marrow, and you can do the immunohistochemistry just to confirm it, right? So these are the things, this is how it works. So you need to know each and everything's differential diagnosis, blah blah blah, interpret one test where it is positive, where it is negative, it is positive in one disease or two, right? So this is a lot of area of discussion, but we'll do it gradually. So here the answer, what is the most accurate test for multiple myeloma is bone marrow biopsy, right? And if even all positive X-ray, you see punched out osteolytic punch out lesion, if it is present, urinary is present, serum protein is positive M band, urine electrophoresis is positive, even all positive, you cannot start treatment without doing the bone marrow biopsy. You need to confirm more than 20% of monoclonal plasma cells. If it is present, it is myeloma. Is that clear to everyone? Yes or no?
Yes.
Okay, so that's all. I
Yes,
think I spoke 1 hour and 30 minutes, probably close to 90 minutes with my all full energy and motivation. So before I end up my session, I would like to have quick feedback on this class. Very quick feedback, honest and genuine, and whatever you felt today, give me the feedback. How did you enjoy?
Sir, thank you so much for this wonderful class, sir. All the concepts were very clear and crisp, and it is like a very difficult topic, hematology. So these topics are made clear now. Thank you so much, sir.
Wonderful. Thank you, Kasturi, for your kind feedback. Anyone else? We'll finish it. We may probably need two, three. Though I took little long time in acute leukemia, but it's important because until and unless you understood the concept, always every time you will get confused. And I try my level best to make it more simplified for you guys because in books again it's little confusing. So I try my level best to make it more simplified. Yes. Yes, Anisa, Ishara, Rahima, Sidra,
Yes,
Sunil
sir.
Kumar.
Thank you very much for excellent lecture. I had always difficulty to understand the leukemia, but you make it very easy, and I cleared my doubts. And thank you very much, sir.
Wonderful. Excellent. So feel free to message me. This is my direct number, especially for hematology, right? I can take all the lectures, but I think I'm super expert in this. So this is my mobile and WhatsApp. Those who do not have for any hematology queries concern, directly post me directly because it's sometimes difficult for me to see the group because of my heavy practice. So post me directly. I'll get back to you as soon as possible by message or voice. Yes, anyone else? Last but not the least, we have still many doctors, Jabar, Ishra, Shabnam, SM, Chandrasiri,
very well
Tomilin.
explained, sir.
Sir, I want to thank you for all the efforts. You are making it very easy for us.
Excellent, wonderful. Thank you very much for your kind feedback.
Sir, thank you very much, sir. You are explaining very complex things in a very simple manner. Thank you very much for your efforts and good luck.
Thank you very much. So we'll connect you with the next class. Probably we'll finish it off hematology and keep in touch. Stay tuned. Get more sincere and disciplined about your exam. The way I'm disciplined about every Sunday, though I would like to also rest for 1.5 hour more, but I'm not doing it just to help the people because I would be happy and glad everyone passed the exam from our group. So thank you very much for joining me and listening me coolly and calmly. And next time you come up with the more questions, I want to solve your queries. So these are the questions probably you have queries, so it is solved. But if you have some specific queries, I don't know, sir, CLL, I don't know CML, I don't know myelodysplastic syndrome, I don't know how to differentiate thalassemia major and sickle, blah blah. That will cover. So when we cover, you clarify. But you get ready. You have whole week for your queries. So you just once again have the opportunity to gather all your queries and discuss with me. Thank you very much and stay tuned. Enjoy your Sunday. Thank you. Goodbye.
Thank you so much, sir.
Goodbye.
Thank you, sir.